Hi, you're watching Nursing It. Today we're going to talk about biliary and pancreatic disorders. Let's start by talking about the gallbladder. The gallbladder is actually just a bladder. It is a collecting kind of sac that's connected to the liver, and the liver produces bile, which is then stored in the gallbladder. And when you eat, the gallbladder contracts and squeezes the bile down the common bile duct and out into the duodenum. It helps with digestion of food. Cholecystitis is the inflammation of the gallbladder, and it can be acalculous, which means without stones, and this is the case in biliary stasis, or it can be calculous or with stones, which is called cholelithiasis. So when you have gallstones, the medical term for that is cholelithiasis, and this is usually a combination of either cholesterol stones, bilirubin stones, or mixed. Even after you have your gallbladder removed, you can still get stones because you have concentrated bile mixed with cholesterol in the common bile duct, and when that gets concentrated, stones can still form. So common bile duct stones are referred to as choledocholithiasis. This is a picture of cholelithiasis causing cholecystitis. So an inflammation of the gallbladder from stones. This causes right upper quadrant pain where the gallbladder is located. And on exam, the patient will have what's referred to as a positive Murphy's sign. So with you pressing in on the right upper quadrant, kind of just to the right of the xiphoid process, have the patient take a breath out. It's going to be uncomfortable. And continuing to press in, have them take a breath in, and you'll notice this sharp and they catch their breath and they can't take a full breath in. That's referred to as Murphy's sign. It's very colicky, intermittent, and sharp because this is a hollow organ, and it oftentimes radiates through to the back near the shoulder blade. Jaundice is possible, but less common with cholecystitis than with liver issues. The signs and symptoms can mimic cardiac pain, so the priority is to rule out MI. You need to get an EKG within 10 minutes of arrival in the ER and perform blood work, like a troponin, to make sure that the patient's not having a heart attack. And then once that is ruled out, X-ray, ultrasound, HIDA-scan, ERCP, we can continue to work up the gallbladder. CBCs, LFTs, and bilirubin will also tell us more about whether or not there's an infection, inflammation, elevated bilirubin, or elevated liver fats. Treatment for an inflamed gallbladder includes making the patient NPO because anything they eat is going to cause the gallbladder to contract, which will cause more pain. Providing them with IV fluids, pain management, and antibiotics. Morphine, interestingly, because of the histamine response, can cause spasms and increase pain, so fentanyl would actually be a better drug in this choice. If they're eating, they should avoid fatty foods and alcohol. So some patients we will send home, especially if they have like an acalculous cholecystitis and they don't have a white count. They may go home and follow up with surgeon as an outpatient. So we tell them to avoid fatty foods and alcohol. They can have the gallbladder removed by a surgeon, either an open cholecystectomy with a T-tube or a lap chole, and which type they have depends on whether or not there's a lot of stones or whether or not there's complications. So if I have my gallbladder removed and they put in a T-tube and that drains bile, what color should the drainage be? This is a picture of a T-tube. So the T-tube drains the bile, which is made from the bilirubin, which causes jaundice. So if you think about what color does the bilirubin make your skin during jaundice, that's the same color that the bile stains your stool and kind of everything else that it touches. So just for a second, look at the bag and notice how kind of yellow food colored, like really super concentrated yellow, almost browny orange this is. That is the color that bile stains things. And then down here, you'll notice that it's a very, very dark brown. And that's because it's concentrated in that area, right? So the staining is the yellow color, and then the concentration becomes very, very brown, just like with yellow food coloring. So moving down and to the left just slightly, let's talk about the pancreas. The pancreas can also become inflamed, and that's called pancreatitis. Acute pancreatitis is an inflammation of the pancreas, oftentimes related to alcohol or gallstones that can obstruct the common bile duct, leading to a backup of pancreatic enzymes and juices, or the pancreas can be injured during trauma. The patient will have left upper quadrant and epigastric pain that radiates through to the back on the left side and the shoulder, the left side. Deep, sharp pain that increases after eating, nausea, vomiting, anorexia, abdominal fullness, hiccups, indigestion, fever, tachycardia, and hypotension are all common. Think about for a second where the pancreas is located, and then think about the fact that pain that radiates up to the shoulder oftentimes follows the phrenic nerve, and the phrenic nerve innervates the diaphragm. So things like hiccups and radiating shoulder pain makes sense when you think about the fact that the pancreas is up against the diaphragm and the phrenic nerve. Acute pancreatitis has labs that are kind of fairly predictable. So we want to look at the amylase and the lipase. So these are pancreatic enzymes, and amylase rapidly increases and lipase will be elevated. We're going to look at the BUN for evidence of dehydration, as well as white blood cells for evidence of infection or inflammation, and our LFTs, because our liver function tests will elevate if we have obstruction. We'll look at the glucose, that oftentimes is elevated as well, and then we'll look at the calcium to see if it's low. So calcium is oftentimes decreased in acute pancreatitis due to fat necrosis, hypoalbuminemia, malnutrition, and in alcoholic pancreatitis, we see all of those as well as hypocalcemia. So tingling around the mouth, the lips, the face, the hands, the feet, Chvostek sign where you tap on the cheek and it kind of spasms, or Trousseau sign where you blow up the blood pressure cuff and leave it inflated, and the forearm spasms. Ultrasound, CAT scan, and MRI are all diagnostic tests that can be used to evaluate the pancreas. If we have acute intra-abdominal bleeding, we may see Cullen sign or Gray-Turner sign. So just look periumbilical or flank, like retroperitoneal, for evidence of intra-abdominal hemorrhage. Treatment would include NPO and an NG tube hooked to low intermittent wall suction. Parenteral feedings with either PPN or TPN would be introduced to allow the gut to rest. IV fluids and pain medications, morphine, fentanyl, would be appropriate. Antibiotics are used only if there's evidence of necrosis. Surgery can be performed, it's called a sphincterotomy, to dilate or open the sphincter to allow the juices and the enzymes to escape. In addition to that, some anticholinergic agents can be used to decrease intestinal motility, which decreases the release of the pancreatic enzymes. Spasmolytics can be used as well to release or relax the sphincter of Oddi. H2 blockers or PPIs can be used to decrease gastric acid secretions. And then if the person is eating, pancreatic enzymes can be taken to help digest fats and proteins. And octreotide decreases the secretion of enzymes inside the pancreas. We do have to watch out with octreotide, however, because it does increase the risk of gallstones. Acute pancreatitis complications include necrosis, hemorrhage, and pseudocyst. So necrotizing pancreatitis, just like necrotizing fasciitis, when you think about like gas gangrene, there's gas or air bubbles seen on the CAT scan. So kind of this autodigestion occurs, and the side effect of that is gas. So there's air bubbles. The patient goes into sepsis or multi-organ dysfunction, and they become infected. So they can do what's called a necrosectomy. So they go in and just remove the necrosed area. They can also have a rupture and hemorrhage. So we talked about Cullen's and Gray Turner, but watch for signs and symptoms of hemorrhagic shock. Patients can also develop what's called a pseudocyst, and this is just a cyst within the pancreas that's full of enzymatic juices. It may or may not resolve on its own. If it doesn't, they can drain it. Antibiotics are only used if it's infected. Antibiotics are not routinely used for acute pancreatitis because it's not usually infection in nature. Pancreatitis can become chronic, and this leads to chronic inflammation and scarring. Then that leads to problems with digestion of proteins and fats, as well as problems with glucose balance. So then we have problems with our alpha and beta cells in the islets of Langerhans. Patients who have chronic pancreatitis will experience weight loss, left upper quadrant pain, and it gets worse after they drink alcohol or eat fatty foods. Oftentimes they have nausea, vomiting, diarrhea, clay-colored stools because there's a lack of bile, and steatorrhea because they don't have good pancreatic enzymes to break down the fat within the food that they're eating. Chronic pancreatitis can be diagnosed via ultrasound, CAT scan, or ERCP. Monitor the amylase, the lipase, alkaline phosphatase, bilirubin, and glucose. Treatment should focus on pain management and fluid and electrolyte balance. Replace pancreatic enzymes if the patient's eating, and if they're NPO, then PPN or TPN to maintain nutrition. Surgery would not be curative, it would be palliative. Some patients will develop pancreatic cancer. Unfortunately, the onset is very vague, and it's often malignant prior to diagnosis. The mortality rate is very high, and the person usually experiences pain, weight loss, and jaundice by the time that it is discovered. The treatment for pancreatic cancer includes chemotherapy and radiation, as well as Whipple's procedure. With Whipple's procedure, the head or kind of the area of the pancreas that has the tumor, which is usually the head of the pancreas, is removed. And then the neck of the pancreas is attached to the small intestine. The stomach then is taken off of the pylorus and attached further down on the small intestine. So the pancreas is draining into the small intestine above the level of the stomach. When they do this surgery, so this is called Whipple's procedure, when they do this surgery, they will insert an NG tube in the operating room. The purpose of the NG tube is for decompression. It will be hooked to intermittent low wall suction. It should never be clamped. It should never be flushed. It should never be repositioned. It should never be irrigated. It should never have anything inserted or instilled through it. It is not for medication administration. It is not for feeding. You do not check placement. You leave it alone. It is only for decompression so that there is no buildup of acid, gas, fluids, anything inside the stomach that would put pressure on these suture lines. Anytime you have a GI surgery, the post-operative NG tube is totally different than an NG tube that's inserted for lavage or gavage or feeding, or even different than inserted for bowel obstruction. It's really critical that you recognize the purpose of the NG tube that is placed for each patient that you're caring for that has one, because you could critically injure somebody if you just start repositioning it or flushing it. You could blow out those suture lines and cause a massive kind of perfed abdomen. So that is biliary and pancreas kind of in a nutshell. Thank you again for watching, and I hope you enjoyed this.